time, but sometimes these other issues crop up that cause problems. And the ones that I would ordinarily focus on if I was covering more broadly would be not only psychosis and cognition, but also depression and anxiety, they're sometimes lumped together and called affective disorders, impulse control disorders, Indu mentioned briefly. And then there's other things that kind of fall under psychiatric, or at least certainly non-motor, like rapid eye movement, sleep behavior disorder, or RBD as it's also known, and changes in motivation such as apathy and disorders of disorders of sleep and wakefulness like excessive daytime sleepiness. All right. So what are some of the caveats? So many Parkinson's patients don't have psychiatric or cognitive complications. And if I don't say that up front, then I always feel like I'm scaring people or making the situation seem really dire or dismal. So many don't have these issues. Psychiatric and cognitive complications are not the fault of and do not represent weakness in a patient. And that's true for psychiatry in general, but more so even for Parkinson's disease, where there's a disorder that affects the brain, and the brain is where psychiatric and cognitive symptoms spring from. So there's overlap between the illness and its effects on the brain and these symptoms I'm talking about. Most Parkinson's patients I've always been impressed or cope extremely well, given that they have a chronic, progressive, and sometimes disabling illness. The family members and caregivers or informed others of Parkinson's patients are in general remarkably supportive and understanding. I mostly see people with somebody else. It's more uncommon for me to see patients by themselves. I'm typically seeing them with a spouse or with an adult child or somebody. And I'm always very impressed by how good these relationships are overall, supportive. And some of the caveats is that that's come to the fore more recently is that having an illness sometimes can have unrecognized beneficial effects. We just talk about symptoms and problems that arise with illnesses, but there can be unrecognized or unintentional benefits sometimes. So for instance, some of the medications that are used to treat some of the motor symptoms may actually have potential mood enhancing effects. There may be enhanced creativity in a positive way for people that are on certain medications, such as dopamine agonists. And also when we've done some qualitative interviews, just asking patients and their spouses primarily in an open-ended fashion about the illness and its impact on them, their relationships, that there seems to be a greater understanding and appreciation of life, strengthened marital dyads sometimes, marital relationships. And I think it's not necessarily specific to Parkinson's disease. It can happen with other illnesses as well, but it's not something to be underestimated or unrecognized, I think. Okay, so with that background, I'm going to cover two disorders briefly, and then we can just have conversation about comments, questions about anything. So psychosis. Psychosis to a psychiatrist means hallucinations or delusions, sometimes both of them together. And hallucinations in Parkinson's disease, so hallucinations means you are having a sensory experience in the absence of a true stimulation. And the ones that are most commonly reported in Parkinson's disease historically are visual hallucinations, so seeing something that other people aren't seeing. But we now recognize from more recent research that if you only ask about visual hallucinations, you're going to miss part of the story, maybe an important part, because we know now that auditory, olfactory, and tactile hallucinations can also occur. Auditory being hearing things, olfactory, smelling things, and tactile, touching, feeling a sensation of touch. And it's interesting because very few Parkinson's disease patients, by the time they're diagnosed with the illness, can smell normally, but yet you can still have olfactory hallucinations. Related to visual hallucinations are a milder phenomenon or an earlier phenomenon called illusions, which are the actual misidentification of an actual stimulus. So there's really something there in your field of vision, but the person will misidentify what it actually is. And then there's even more, perhaps early or mild, minor changes called passage and presence phenomena. And passage phenomena is a sense of something moving in the periphery of your vision, and presence phenomena is the sense of somebody being, a person being in the periphery of your vision. You can't actually see the person in front of you, it's off to the side, and those are called passage and presence phenomena. So those are kind of the broader category of hallucinations. Delusions are when somebody has a fixed false belief, so believes something to be true that other people don't believe to be true. And it typically happens after hallucinations have occurred. It tends to be in those with more severe cognitive impairment. And the most common type of delusions are what we call paranoid delusions or persecutory ideation. So for instance, a common theme may be that one's spouse is being unfaithful to the patient, or that there's intruders in the house. It can really take any presentation, but those are two common examples. And if these symptoms overall become severe enough, they can lead to institutionalization. It's been shown to be one of the risk factors for institutionalization, because sometimes when these symptoms become bad enough, patients can become agitated or aggressive. It can infect the sleep of both the patient and the caregiver, informed other, and it's a big strain on the person who's living with the patient or caring for the patient. Okay, next. So what's the etiology or cause of psychosis in Parkinson's disease? Well, it's complex. It seems to be perhaps a mix of Parkinson's medications, increasing severity of the illness itself, cognitive impairments, so impairments in memory and other thinking abilities put people at risk. Visual impairments, Parkinson's patients can have all kinds of issues with double vision, impaired vision, and those may be associated with hallucinations as well, older age. And then if somebody has other accompanying psychiatric conditions, such as that REM behavior disorder that I talked about, that seems to be associated with this. The one point to make about that, though, is when we're asking patients clinically about these symptoms, sometimes somebody will say, oh yeah, I woke up in the middle of the night, or I was dreaming and I saw this. When we're talking about visual hallucinations, we're talking about something that happens in really the fully awake state, not while somebody's sleeping or falling asleep or coming out of sleep. Those are sleep-related phenomena that we usually categorize or think of differently than true hallucinations. So it seems to be probably that there's a complex interaction or mix of reasons why people with Parkinson's disease may experience these psychosis symptoms. And it also seems to be linked with three key brain chemicals: dopamine, which is characteristic of Parkinson's disease, a deficiency in dopamine, but also not only plays a role in motor symptoms, but likely psychiatric type symptoms as well. Serotonin, which is another key neurochemical or neurotransmitter, and acetylcholine, which is most closely linked with cognition and thinking abilities. But all of these have been shown in one way or another to play a role in Parkinson's psychosis. So in terms of clinical management, to make this very, practically focused as possible, there's expert opinions that have been updated over the years in terms of what to do with the Parkinson's medications, if you think that that's playing a contributing role. And there's an order that's usually followed in terms of discontinuing medications, anticholinergics, which are not used so commonly to treat Parkinson's disease, at least in the United States, amantadine, which is used for dyskinesias primarily, dopamine agonist, MAOB inhibitors, monoamine oxidase B inhibitors, and then finally levodopa. So at the end of the day, by the time I often see somebody who has psychosis with Parkinson's disease, all of these other medications, except for the carbidopa, levodopa, have been stripped away, and the person may be just on carbidopa, levodopa at that point. In terms of if that doesn't work and you've evaluated to make sure the person doesn't have an acute medical condition that might be causing hallucinations, such as a urinary tract infection or pneumonia, sometimes we do have to resort to using antipsychotic treatment. At any given time, there's a fair amount of Parkinson's patients that may be taking an antipsychotic. And the issue with antipsychotic use in Parkinson's disease is balancing the potential benefits, which are improvement in hallucinations and delusions, and the potential risk, which include worsening of the Parkinson's symptoms, so worsening tremor, stiffness, slowness, balance, and gait. We used to have a class of antipsychotics called typical antipsychotics, which we hopefully don't really use commonly at all in Parkinson's anymore, and now have a class called atypical antipsychotics, There's one in particular that's most commonly used in Parkinson's disease called quetiapine, or Seroquel is the other name for that. We have a wide dosing range that can be used. The issue with quetiapine is that to date, we don't really have good scientific evidence from Parkinson's disease studies that it's helpful. And we hope to we will be investigating that further in a Department of Veterans Affairs studies that Indu is going to be involved in. Another medication that falls under the atypical antipsychotic class that has been shown to work in Parkinson's disease is clozapine. It's an older antipsychotic. And there was 2 primary studies that shown that it was helpful. The issue with clozapine is that it requires routine blood monitoring to check for a decrease in white blood cell count that can occur rarely with this medication. So it means that for the first 6 months that you're on the medication, you have to have your blood drawn weekly. For the next 6 months, every 2 weeks. And then once you've been on the medication for a year, you can have your blood drawn just monthly. But that's enough of a burden on patients that clozapine is very rarely used, even though it's been shown to be helpful. And then finally, we have a newer medication I have recently here, but it's been 3 years now since this newer compound called pimavanserin, or Nuplazid, has been approved by the FDA for the treatment specifically of Parkinson's disease psychosis. And one of the interesting features, perhaps helpful features about this medication is it affects one system, serotonin, but not dopamine. So it's hopefully helping with the psychotic symptoms, but not blocking dopamine to worsen the motor symptoms. And so far, the studies have looked positive for that, leading to the FDA approval. There's also been a more recent study for patients with dementia-level cognitive impairment, including Parkinson's dementia, that was positive, and they've gone back to the FDA for approval for that population, specifically patients with dementia. There have been issues raised, particularly in the popular press, about concerns about an elevated death risk, mortality risk in patients exposed to this medication. But we have concerns about all antipsychotics, I would say, in this regard, particularly in patients with dementia. That's been shown for Alzheimer's disease. It's also been shown even for Parkinson's disease, that there may be a slightly increased risk of death with these compounds. And it's not specific to any one compound as far as we can tell, but to the overall class antipsychotics. So we need to be mindful of that when prescribing these medications and letting patients know of any not only potential benefits, but risk associated with them. All right, so that's psychosis. We can go through cognition now, and then we will have ample time for conversation. So cognition, cognitive changes. So I'm thinking of the best way to introduce this. This nomenclature or terminology or wording is all borrowed from the general population and from Alzheimer's disease. So when we assess a person as part of a clinical research study, and we assess their memory and other thinking abilities, and then assign them a diagnosis, patients can basically fall into one of 3 groups or buckets. One bucket is normal cognition, which means the person probably doesn't report any significant cognitive changes compared with pre-Parkinson's disease. They score well or well enough on their testing, whatever cognitive testing they're administered, and they haven't reported any significant functional decline from a cognitive standpoint over time. If somebody then, the next bucket would be mild cognitive impairment. So here a patient is typically reporting that they've changed in some way since they've had the illness. They show some level of impairment, usually at the milder impairment end on the neuropsychological or cognitive testing, but still are overall functionally intact enough to conduct their day-to-day activities. So we would call that mild cognitive impairment. Then dementia would be the final category, and that's when there's more severe impairment on the neuropsychological testing. And in addition, the person is reporting significant functional impairment such that it's interfering with their life in some meaningful way. Okay, so that's Parkinson's disease, normal cognition, mild cognitive impairment, and dementia. One area that's still confusing to everybody, including the people involved in the field, is what's the difference between Parkinson's disease dementia and dementia with Lewy bodies, because those terms are thrown about a lot And other related terms are used like Lewy body disease and Lewy body dementia. And basically the one point I'd like to make to you is that as things stand, more or less, to get a diagnosis of Parkinson's disease dementia, it means you've had the Parkinson's disease already for some period of time, and then you develop significant cognitive impairment. To meet criteria for dementia with Lewy bodies, you have to have had the dementia first, and then you may develop symptoms of Parkinson's disease, and then you would meet the criteria for dementia with Lewy bodies. Now, that's not exactly true what I just said, but that kind of gets you the general picture. The other question, another question I'm often asked is, if you have Parkinson's disease, am I going to get Alzheimer's disease? Or can I get Alzheimer's disease? And the answer to that question is both a no and a maybe. The no is that once you've been diagnosed with Parkinson's disease, you're not diagnosed clinically with Alzheimer's disease. You would be diagnosed with Parkinson's dementia or Parkinson's mild cognitive impairment. You don't give an additional clinical diagnosis, not at this point. The truth of the matter is, though, if you look at the brains of people when they die, including the brains of people with Parkinson's disease, some of them also happen to have the brain changes of Alzheimer's disease. You're not immune from that. By the time people reach age 90, close to half of them have evidence for Alzheimer's disease. So a Parkinson's disease patient who dies at age 90 has a 50% likelihood of having Alzheimer's disease just on that basis. So there can be mixed pathology, mixed diseases that we may not fully appreciate or be aware of while somebody's living. All right, so let's get into risk factors, or yes, risk factors. Increasing age, so the older you are, just like Alzheimer's disease or most dementias, higher age. Increasing severity of Parkinson's, so the more widespread the illness is in the brain, the more likely you are to have cognitive impairment. Male sex is a little more controversial, but most studies, I would say, show that males more than females are likely to have significant cognitive impairment, or it's at least equal, if not in favor of males. Less formal education is a general risk factor for significant cognitive impairment. What are called atypical Parkinson's features. So those are people that have less tremor, but more rigidity and balance problems. And that's what's sometimes called the akinetic rigid syndrome, or the postural instability, gait difficulty type of Parkinson's disease. In terms of the impact of deep brain stimulation, more people are getting it now. Perhaps 15% of Parkinson's patients get DBS at some point. And there's been a recent review and several studies that show there can be, on average, mild decline in certain abilities, memory abilities, what are called executive abilities, which I'll get to on the next slide. So maybe some specific cognitive impairments. Many people with who go through deep brain stimulation do, most people I should say, do fine from a cognitive standpoint, but it seems like there's a subset of people that struggle more. More recent studies have shown that younger patients, or people earlier in the disease course that get the DBS, seem to do better cognitively than people that are older and with more advanced disease, which is not surprising. And it might be a mix of both the surgical procedure itself, going through certain parts of the brain that may lead to some cognitive changes, or it could even be due to some of the stimulation effects. When we talk about cognition and Parkinson's disease, we talk about 5 main domains where specific tests tend to fall into one of these 5 domains, or a couple of them maybe. So executive impairment is the ability to plan, adapt, solve problems, work with concepts, ideas. That's executive abilities. Attention impairment is the ability, or attention is the ability to sustain one's focus on something. So here we look at reaction times and ability to sustain a task over time. Sometimes we note that patients with Parkinson's disease can have fluctuations in attention, which is slightly different, but certainly clinically relevant, where people can seem very alert and with it at some times, and at other times seem to have a lot of trouble with their attentional abilities. Visual spatial abilities has to do with one's ability to work with objects in 3 dimensions or in space, or to conceptualize them in space. It's a hard term to describe, but I always think of it as the kinds of skills you need in driving a car, judging distances, seeing objects come from other directions. So that kind of three-dimensional navigation is what we mean by visual spatial abilities. Memory is the ability to learn and remember or recognize information. It can be tested through words. It can be tested visually through pictures or symbols. And the memory impairment, when it does occur in Parkinson's disease, may be slightly different than the one that occurs in Alzheimer's disease, a different type of memory issue. And then finally, language skills, which probably are relatively well preserved early in Parkinson's disease, but you do hear complaints from people about word finding problems or name finding issues, commonly reported, more of a nuisance often than anything else. So in terms of the treatment, so we have treatments that we use. There's only one treatment that's FDA approved for Parkinson's disease, and that's rivastigmine. The other name for that is Exelon. It falls under a category what are called cholinesterase inhibitors, and they boost the chemical in the brain that I mentioned before called acetylcholine that's closely linked with cognitive abilities. So this one medication comes from a class with two other ones, but this is the only one that's officially FDA approved. And it is only approved for Parkinson's dementia. It's not approved for Parkinson's mild cognitive impairment. The clinical benefits of this are statistically significant, but perhaps clinically limited, that it's not such a robust effect, although I do use these medications and give people a chance to see if they'll improve on them or benefit from them. The most meaningful side effects are nausea, vomiting, and tremor, although I would say overall these medications are safe and well tolerated. There's a second cognitive enhancing medication approved for Alzheimer's disease. All of these are approved for Alzheimer's disease, and this other one is called memantine or Namenda. That works through a different mechanism of action than the cholinesterase inhibitors. It affects a different neurochemical in the brain called glutamate. And there's been a few studies with a mix of Parkinson's disease patients with dementia and dementia with Lewy body patients. And I'd say the results are mixed. One had some positive results, the other one was negative. But then when they looked at some more detailed cognitive tests using a computerized battery, which may be more sensitive, there did seem to be some improvements with attention and memory using this compound. So this is another one that can be used, and I do use in addition to the cholinesterase inhibitors. What else can be done while we're looking at those limited options I just described and waiting for additional compounds to be developed and tested, including disease-modifying therapies? In theory, anything that's disease-modifying in terms of improving the motor symptoms of Parkinson's disease should be disease-modifying for cognition as well. There's no reason not to think that. But while we're waiting for these other treatments to be developed and tested and approved, there's some limited but practical things that people can do. Cardiovascular exercise and maintaining a good body mass index. So we know that people that have additional medical conditions that are associated with impaired memory and thinking, such as diabetes, high blood pressure, high cholesterol levels, to the extent that you can manage those factors, and that's point number 3, managing the vascular risk factors, and in addition, get regular exercise and keep one's body mass index down in a normal range, may have long-term cognitive benefits. There's also multiple cognitive exercises that people can do. Things that people may enjoy in their own: crossword puzzles, game shows, lots of computerized tasks that people can do. Some are proprietary for sale, some are free. Crossword puzzles. I think I'm going to mention that already. But anyway, the evidence that this makes a difference long-term is limited, but there's certainly no harm in doing it, and it's usually enjoyable for people. Another practical thing is to look at the medication list that somebody is taking. And I'm not talking about Parkinson's medications here specifically, or not directly, but anticholinergic medications. There's many medications that people take, elderly people take, sometimes over-the-counter Benadryl to help with sleep or allergies, that can have what are called anticholinergic effects. They block that acetylcholine chemical that can impair cognition. Benzodiazepines, anti-anxiety agents, also known as, commonly used to treat anxiety in Parkinson's disease. So some of the more common names you may have heard of: Ativan, Xanax, We do use Klonopin or clonazepam for REM behavior disorder at nighttime. All of those can potentially have some adverse effects on memory or thinking, so they just need to be used cautiously. And then finally, opioid medication use. We all recognize that recently we've been and still are in an opioid epidemic. But the issue about those medications commonly used to treat pain initially is that they can not only lead to addiction, but they can lead to some cognitive impairment as well, cognitive changes. Treating psychiatric symptoms. So many psychiatric disorders, depression, for instance, are associated with worse cognition. So theoretically, treating things such as depression could potentially lead to improvement in cognitive abilities as well. And then two final points, getting a good night's sleep. So there's a couple of disorders, REM behavior disorder I mentioned already, but another one that's relatively common in Parkinson's called obstructive sleep apnea, which people don't like to treat because nobody likes to use the CPAP machine. But what we know is that people that have sleep apnea and don't use a CPAP machine tend to do worse from a cognitive standpoint. They're getting very poor night's sleep. They have frequent awakenings and they tend to be exhausted the next day. And when they've tested these patients, they don't do as well from a cognitive standpoint. Another disorder common in Parkinson's disease is orthostatic hypotension. So that's when your blood pressure drops when you go from a sitting to a standing position and you're not getting enough blood to your brain to keep it adequately perfused, as we call it. So when patients have those symptoms, they've also been tested cognitively, and their cognitive performance worsens when their blood pressure is down. So this is another condition that the Parkinson's doctors are very familiar with and very familiar with treatments for, which need to be recognized and treated from a cognitive standpoint as well. So this is the concluding slide for really a more comprehensive lecture, which is to say that we recognize that Parkinson's disease is a motor disease, but that it's also a neuropsychiatric disorder for some patients, that these are symptoms that are increasingly recognized as common and important. So it really shouldn't be thought of as just a motor illness. Otherwise, people are not going to get the recognition and management that they need. Comorbidity of these symptoms is common. By that I mean that if somebody has one disorder that I've talked about or would talk about, it's quite a high likelihood they may have a second disorder as well. So I try to screen, I have the opportunity to do this when I'm seeing patients, is to screen for multiple disorders, not just focus on one. These illnesses are often associated with disease-related brain changes. I didn't go through that in detail today, but it's true. Parkinson's medications and treatments. Medications, I've mentioned some. Treatments include things like deep brain stimulation, appear to have mixed effects. They may help with certain symptoms, but help lead to other symptoms. Under recognition and under treatment of most disorders is common, and that's really not through anybody's fault. It's just the way things are. Parkinson's neurologists have their hands full managing all the symptoms that they're confronted with when seeing a Parkinson's patient. They're not specifically trained to focus primarily on the psychiatric cognitive symptoms, nor could they. And people that are used to working with these symptoms, psychiatrists or other professionals, they're not so common to have experience with Parkinson's disease. So for all of those reasons, I think they're still probably under recognition and under treatment. And we still need new treatments, clearly, for these disorders, whether they're medication, other types of biological treatments, behavioral treatments. We know that psychotherapy or counseling can work very well for depression and anxiety in Parkinson's disease. Most of the treatments we use, though, are borrowed from the general population or from other populations and not developed and tested specifically for Parkinson's disease. One exception is that newer antipsychotic I mentioned. But moving forward, we really need to get some more targeted treatments for these disorders. And with that, I can finish, and I'm done.
That was great. I mean, you basically really went through two of the non-motor issues that are in this realm, and of which there are many more. And I think almost each of them deserves their own sort of lecture because it's, you know, they're complex issues. There have been an interesting couple of questions that have been posted here. One is, is there a benefit for screening things like cognition and psychosis and these other things from diagnosis with Parkinson's? Or should we wait? It should come up.
I think yes, and I can't say it's because we've got the best treatments or we can treat everything right away. I think it's more for, I think patients have a right and should be informed of the nature of the illness, what they might expect over time. And so I think part of that is having at least annual screening for memory and thinking abilities with a global screening test, and routine monitoring. I don't know if it has to be every visit, but routine monitoring at least annually of mood, anxiety, hallucinations, and so on. Um, Partly it may inform the management for the Parkinson's doctors about what medications to use. It may lead to introduction of psychiatric treatments. It'll help the patients and their family members kind of anticipate and know what to be on the lookout for, because sometimes these symptoms start mildly or innocently enough, and then they progress over time. Certain ones like impulse control disorders, like the compulsive gambling, buying, sex, and eating behaviors, you have to be very vigilant about from the earliest period, because that can get out of control quickly. So there's an example of one disorder that really has to be asked about at every visit, I think.
And one thing we didn't mention, Dan, is screening, maybe some labs and other things. What tests would you do if somebody comes in and starts complaining maybe of new cognitive issues? And also if there's any tests that one would do if there's a new onset of hallucinations. Maybe we could just talk about, sort of the approach.
And you'll be able to weigh in probably on some things. I would tend to do a much, or be a part of a much more basic battery. So that would typically involve a urinalysis, obviously vital signs to check just to see if there's a temperature and pulse and blood pressure. But a urinalysis, a complete blood cell count to look for white blood cell elevation, a chemistry, because sometimes abnormalities and things such as sodium or potassium can be associated with mental status changes. For psychiatrists, sometimes things such as a thyroid hormone level, because either if the thyroid is under or overactive, it may contribute to mental status changes. Vitamin B12 level and folate. Traditionally in the past, but not so much anymore, we would do things more unusual like syphilis tests, but that's just not a common enough condition in this population. Those are the things that probably come to mind. So, I mean, if somebody's having respiratory problems, maybe a chest x-ray, a CAT scan could be done. The CAT scans typically aren't so informative though, unless you're, because you're typically looking for like a stroke or something of that nature, and that would be not so usual and maybe would be presenting through the neurological exam anyway. So that may not be routine. What do you think, Indu? What else would you add to that list?
I think those are all pretty good. One question is vitamin D levels. Sometimes I know people have emphasized that and underemphasized it. What's your thought on the vitamin D?
Well, the only issue with vitamin D is, one is I think the evidence linking it with particular psychiatric or cognitive disorders is limited. That's number one. Number two is it seems like whenever we check it, it's always low. So I don't know what you do, and 90% of the time it seems to be at the low level. So I don't know if that's just Parkinson's patients or it's the nature of the test, or but what's your experience been with vitamin D?
Yeah, I mean, John Duda, who works closely with you and I, have talked a lot about this, and I think that he likes to keep vitamin D above 40. And even in the sunny climates, which are, where I live, everyone seems to have an abnormally low vitamin D. So people have talked about keeping it in our Parkinson's population, closer to above or around 40. So, in that high or even slightly above range. There's a question about if there's any nutritional supplements that you recommend outside of, maybe you talked about B12, folate, and the vitamin D we just talked about. Are there any other things that you recommend for patients? I know there's been some thoughts on maybe curcumin and turmeric, sort of supplementation. I don't know if you have any thoughts from your perspective of any of these sorts of things being helpful.
Well, you and I have had this conversation, and you mentioned Dr. Duda already. I think you all are more at the forefront and stronger advocates, maybe. I think I'm just behind the curve, and I tend to rely on more when the scientific evidence clearly emerges in support of something, and I don't, either I'm unaware of it or it's just not there yet. But I think all the things you're mentioning are very safe and well tolerated, including vitamin D. So I think there's relatively little harm in doing any of these things.
Yeah. There's a couple questions just on, what's the relationship between cognition and hallucinations? So does everyone who gets psychosis have to have dementia, or, is it predisposing factor? What's the sense of that?
Yeah, I think that's the way to look at it, that it's more a predisposing factor. And the exact explanation I wouldn't know, because when you're cognitively impaired, there's so many other things that you are besides cognitively impaired on average. So for instance, you're older, you're typically have had the illness for longer, you're probably on higher dosages and more Parkinson's medications than somebody who's not cognitively impaired. And it's hard to separate out, is it the cognitive impairment or one of these other factors that's leading to the increased risk for psychosis? But clearly, if you take a group of patients with and without cognitive impairment and look at their rates of hallucinations and delusions, it's always going to be higher in the patients with cognitive impairment. And I do think at least a part of that is that those patients with cognitive impairment have the illness typically that's spread outside of the motor center of the brain and is spread more broadly or widely, including areas that are probably more closely associated with hallucinations and abnormalities and thinking, like delusions.
Yeah, that sounds about right. Another couple questions. So what's the role maybe of formal neuropsych testing? And you mentioned DBS as well. Maybe we can talk about it in the setting of a DBS evaluation as well. And maybe you can even describe what it is.
When we do screening, as I call that, for cognitive impairment, there's multiple tests, and maybe one in particular that most people would be familiar with, called the Montreal Cognitive Assessment, or the MoCA. So a screening instrument typically should take less than 10 or less minutes, maybe 15 at most, and covers all of those major domains that I talked about. And that's a quick way to get a sense of overall cognitive abilities. But that's probably the most superficial level of testing. Then there's more detailed testing, and that might be when you go to a neuropsychologist and the person sits down with you for 1 to 2 hours and does a series of very detailed tests that will give you the most information about your relative strengths and weaknesses compared to other people in the population. And so there's that, and now we've got, in the midst of this COVID-19 epidemic and how the world has already changed and likely to continue to change for the foreseeable future, we now have to think about, can these tests be done remotely? Because we're not going to be seeing people in person in the same way, at least for the time being. So now we need to think about whether these tests can be administered through telephone, through video. There's also people developing tests, which is really quite interesting and I think exciting, where patients can self-complete these tests at home on a computer. So ways to test your memory or thinking abilities where you don't even need anybody to administer you the test. You just need you and a computer, and then you complete the task and it gets scored, and then the clinician or researcher can see your test results. So there's where we are now, but I think where we're heading relatively quickly.
Right. There's a question about, can you just mention the medications that adversely affect cognition again? You had mentioned, I think, Xanax, Ativan. Maybe you could just briefly touch on those, if you don't mind. Just
3 main categories. One comes with a very big list that you can look up. It's called the Beers list, B-E-E-R-S, Beers list of inappropriate medications in terms of anticholinergic properties. And this includes all of the medications that are commonly used for the treatment of medical conditions, and where they rank on the list of anticholinergic properties or anticholinergic effects, which may impair cognition. So you can look up that list and see if your medication is on it. And then sometimes people are on more than one of those medications. That's one. Then there's the class called benzodiazepines, or anti-anxiety agents. Those include medications such as lorazepam, which is Ativan, diazepam, which is Valium, alprazolam, which is Xanax, clonazepam, which is Klonopin. Sometimes people use temazepam for sleep, and that's Restoril. There's many medications. They all end in PAM, and they all potentially can worsen. I'm not saying they do worsen, but potentially can worsen cognition. And then finally, opioids or narcotics. People take oxycodone, hydrocodone, codeine. Sometimes they take stronger things, morphine, depending on the pain. A related medication used commonly in the elderly, it's not formally classified as a narcotic, but it has narcotic-like properties and can impair mental status in elderly patients sometimes is tramadol or Ultram. That's another one that's notorious for causing mental status changes in the elderly. So those are the pain type medications to be on the lookout for.
Okay, that's helpful. There's been a question or two about REM behavior disorder and what the best treatment is for it, from your opinion.
Yeah, so we're really just based on clinical evidence here, because there have been very few studies, and the relatively recent smaller studies for both clonazepam and then melatonin, which everybody's familiar with, have both been negative. So we don't have really positive results. I'd say clinically, we have the most experience with clonazepam or Klonopin, maybe 1/4 to 1 milligram at bedtime. And I think we've all had the clinical experience that it seems to help with the vivid dreaming behaviors. Melatonin, I think, is easier to use because it's safer, but there's also relatively little or no evidence of whether it works or not. Clonazepam, like all of those benzodiazepines, are PAM medications, so you have to worry about, keep an eye on cognition, on balance, and on daytime sleepiness. But in general, that's probably the go-to medication. There's some evidence that antidepressants may take a role in worsening or unmasking vivid dreaming behaviors in Parkinson's patients or in general. So sometimes we'll see if a person's on an antidepressant to see if maybe modifications could be made to that.
Yeah, just in the chat, there's been a few questions specifically about certain medicines. We can't address each and every case and every medicine, but in general, dopamine agonists and anticholinergics, such as Artane, dopamine agonists like Nupro Patch, Mirapex, Requip, Ropinirole, and there's a number of other international guests on this, so you'd have to look up sort of what's the specific medications in your own countries. Those can increase the risk of cognitive issue manifestations as well as hallucinations. So I think one of the bottom lines from this is that, you know, the approach should be that you sit down and systematically look at whether there's treatable causes, like you mentioned, a urine infection, salt abnormalities, or you know, thyroid, B12 issues, things like that, that are treatable. If there's a new infection, even sometimes in the body, if there's a skin infection, sometimes it can cause these issues. And then go through systematically the list of all of your medicines that you're on, bring it in and take a look at it, and then, you know, revisit these medicines. There's also been a question on the chat of, if all these meds cause problems, is it better to take natural things? And things like mucuna would not be something that I would recommend. I think we end up sometimes paring down, as Dan showed, you know, taking medicines like our anticholinergics, pramipexole, sometimes substituting more sort of Cinemet type preparations, levodopa preparations that are less likely to cause problems, and sometimes even minimizing those as well. But we are not recommending going off of all your pills or anything. One last question, Dan, and then maybe I'll also give you a couple minutes to just talk about some inspiration and what you hope and you know, your thoughts are for the future of this area. If there's any low-hanging fruit medications that are exciting to you. But I just wanted, there's one or two questions about marijuana and CBD, as you probably expected in this type of group. So maybe you could just mention what your thoughts are for using those in cognition as well as hallucinations, and or if they affect them adversely. And then maybe just give us a few inspirational thoughts.
I don't have experience treating patients with it. I've just consciously chosen not to become a provider for CBD or THC. I just thought it would be too complicated for me to try to master that. There's just so many different preparations available and forms of administration. I'd say the evidence in any medical condition is very limited. The evidence in Parkinson's disease is very limited. I can kind of make the case most strongly in my mind, or from what people have told me anecdotally, that perhaps if you have severe anxiety symptoms or maybe significant sleep issues, some of these treatments may be helpful, but I can't really say for sure. I do worry, at least with the THC preparations, whether that's going to worsen or affect people's cognition in an adverse way. Less worry about that with the CBD preparations. But I don't have more to say about it. I think there's going to be lots of studies in the coming years, and the question will be answered. And inspiration, gosh, I don't know. What can I say that's inspirational? I guess I get my head in the a forest that I don't look for the trees sometimes. So I get so caught up in just day-to-day work in this area.
I would say maybe what are your, if you thought about the non-motor symptoms, what are the things, let's say if we had, 10 new researchers that had just graduated from fellowship, what would be the things, now that you've been in practice for the years that you have, what would be the non-motor things that you would want them to tackle first? Maybe we could talk about that.
I think cognition has to be at the top of the list, and that's not breaking news to anybody, but I think that's the one game changer for people, is when they develop significant cognitive impairment. It just makes everything so much harder, because not only then are you facing these motor symptoms, but you lose your, it makes it harder for you to be independent in other ways. And so that would be that one. I think we've made progress in terms of our management of psychosis, but I think psychosis, so kind of frightening hallucinations or delusions, are still a major problem, disruption for people. So I think that would be number 2. And then I think these affective changes, depression, but even more so for some patients, anxiety, these panic attack, anxiety attacks that can occur. I think if we were able to better address each of those 3 and the vivid dreaming behavior, patients would be able to manage much better, better quality of life, better relationships without this disruption. Yeah.
Okay. I'm kind of thinking apathy would be one of my topics. I think that it's so, it affects so much, and it really sometimes affects the dynamics a little bit. So I think it would be great to, maybe have you back on at some point if we can twist your arm and maybe talk a little bit more about impulse control disorder, which you've made some huge strides in. But I wanted to get, something on cognition, something on psychosis, and we could literally meet up every weekend. There's been some amazing sort of comments here that people have really enjoyed this. It's been a great presentation. Like that. So we really appreciate you taking the time out of all of what you do, and you've been trying to keep pushing the field ahead and doing, important trials and just systematic research and thinking about these questions in a very systematic way, which I think is really needed, and working so well with your neurology colleagues across the world, which has been really, really fun. And we had Ray and some of the other non-motor study group gang from the Movement Disorders Society come on. And I think it's just been a really beautiful working relationship that we've all developed with working through some of these things that I think, as I agree, I think we've done a lot of strides towards improving motor outcomes, but the quality of life in many of our patients continues to be in these realms of the non-motor aspects, and especially the neuropsychiatric aspects. So I really thank you so much for coming on, and I'll pass it back to the PMD Alliance gang to send us off with our final wave. Goodbye. Thank you.
Right.
Thank you.
Thank you. Thank you, Dr. Weintraub. Thank you, Dr. Subramanian. And thank you to everyone who joined us today. So let's say our goodbyes and our wave. And see you all soon.
Thank you.
Thank you so much.
Bye.